We've struggled trying to get patients off Kratom and Suboxone. Do the panel have any ideas on those two generally? Yep.
Yeah, so Kratom, if it's true Kratom, will act, right, because you're getting it at the mini mart or whatever. True Kratom is going to act very similar to a low-dose opioid, right? So LDN will function in a similar capacity to help that in the same way you would wean from a narcotic, right? Ultra low dose, tapering down, you've got the benefits from the dopamine system, you've got the neural inflammatory benefit, right? You've got, that should work, right? Suboxone, a little different. One, I would say, why are they on Suboxone? If it's medication-assisted therapy, then do not touch it. Do not take them off unless they are well years out, because the data for that, regardless of everything else, is very effective and reduces relapse and does work. So I would say that. If you're doing it for pain, then it's sort of interesting because that target buprenorphine is primarily, not entirely, but primarily a kappa antagonist, so, or partial, I guess. If you're using Naltrexone for it, you are crossing over into those kappa and trip receptors and being able to, in theory, kind of replace one with the other over time in a very similar concept. But weaning in general is hard. Slow, frequent visits, adjuvant therapies, of which there's a lot, small doses. Generally, I would say if you're dealing with weaning or taking people off, you kind of gotta either do it slowly or have somebody you can access that has done this and knows, like a pharmacist or another provider or something like that.
Thank you. Anything to add on that, Sebastian?
I've got to be really, really cautious, because this is a very important understanding, is that you can use other pain management medication at the same time. And once you start changing their pain understanding that this might not be working for you, we've got better pain control medication management with much lower doses of naltrexone to start breaking patterns of dependence. So we're talking 0.5 milligram doses, maybe 2 or 3 times a day, just to start breaking cycles for an extended period of time. And then we can titrate up on the other pain management as we titrate down on the Suboxone with very low doses of naltrexone, and not trying to get into the low dose world or even higher doses, because there's a tipping point of about 1 milligram. Anything you go above 1 milligram, you start interrupting pretty dramatically, and then you can force them into withdrawal, which then you lose trust, then you lose pain control, then you lose the patient, and then you have a lot of people yelling at you. So that's never a good place to be. So it's very, very cautious, very small steps, and working with someone who's already done it. And if you don't know anyone who's already done it, reach out. There's people who have, and we can certainly put you in contact.
I've done this a lot, and I still screw it up. I mean, it's not easy, right? You have something that you're pretty darn sure should work. It's very conservative. You're doing this low dose. You're incrementally taking them off. You added all the other things. Call you up mad because they're in withdrawal, right? So obviously all the other things, good patient relationship, communication, education, all those things are going to matter. Mechanistically, if you don't tip them over the scale, you should be able to swap somewhat effectively and augment that.